I love to speak to doctors and actually lay people who want to facilitate physicians to break out of the system, which I believe is very detrimental, not only to physicians, which is my main focus, but of course that trickles down to the patient.
Welcome. It is Wednesday, time for Health, Biz, and Politics. We have a good show for you today with the brave goddess of medicine joining us. Let me share the screen for those of you who are new show you our website where you can find the latest information, who our speakers are, learn a little bit about them, and so on. And I will add, we do have a new site. You will come over to your-mp.com and click on Your Media Hub, which will take you to this page. Everything is a little bit new. We are still working on it. You'll see boxes here that we need to fix. Anyway, going down, you can subscribe. We recommend that. We have our Wednesday and Thursday show. Who's there? Take a look. And then after the show, usually by Sunday or Monday, we have the videos up and we post them here on BitChute, Brighteon, YouTube, etc. So we made that nice and easy. Kudos to Jane for putting those nice buttons in there. Okay, so I think that's it. Let me stop the share and turn it over to you, Charlie.
Thank you, Jim, and welcome, Dr. McKnight. Obviously, in your opening remarks, we're going to want to explore that phrase, brave goddess of medicine, a little more. And in the preview, you discussed some profound points, particularly the trigger of the vaccine hysteria and tyranny, as making doctors ready to make the jump, because some of them, I think, are guilty for going along with some of the totalitarianism and the protocols in the hospitals, especially, that proved criminal and horrific. But a lot of them were just regular folks, maybe hopefully with an independent bent, maybe with a tad bit of the Hippocratic Oath driving in their gut that things aren't right, just following pharma protocols, government mandates without questioning, which any sane person has certainly done over the past 3 years. And even outside the COVID pandemic, even before that, in the 5 years weekly that we've hosted this show on health with all kinds of disruptors of the cartel, we've seen a lot of doctors try to get more cash patients. It's a struggle. Certainly the cartel doesn't really support it. The hospitals are doing everything they can to avoid transparency, and the insurance companies have a gravy train with their Obamacare rules to gain the system. And the government just likes its control no matter what, and who pays its bills, keeps them in power. So for the small cohort of doctors going independent and seeking cash, that is an important thing to highlight. And we've had a lot of people like Dr. McKnight present over the years: DPCs, concierge doctors, functional doctors, integrated doctors, regular doctors, specialists, like Dr. McKnight, rheumatologist, Dr. Hodges, Grace Torres Hodges presented a year ago or so on how specialists can get in on the subscription payment game. And what happens with cash are so many good things. The extra time makes doctors better because they're no longer on the hamster wheel chasing claims with reimbursement. Ellen is going to introduce some concepts we haven't discussed enough, probably: the reliance and the trap of electronic health records, how it impacts that short visit with a patient. The maintenance of certification, MOC. We haven't really discussed that enough, I don't think, on our shows. We may share screen ourselves and show a partner of ours, the Wow Cash Appointments app, how that's facilitating the cash transactions. Maybe I'll share also our campaign to replace licensing with certification too, because licensing has been a tool to really hurt maverick doctors that try to treat early during the COVID insanity. So with that, Dr. McKnight, take it away. Tell us what's on your mind, and then we'll have Q&A after that. Thank you.
Thank you. And thank you for inviting me. I'm very thrilled to be here. I love to speak to doctors and actually lay people who want to facilitate physicians to break out of the system, which I believe is very detrimental, not only to physicians, which is my main focus, but of course that trickles down to the patients. What I thought I might do is give you just a little bit about me, just so people know that, and then I want to talk about what I, a little bit about the pandemic, as we mentioned, and then to go on to some solutions, and then also to talk about what I did and why I did what I did, as far as getting out of Medicare was my primary claim to fame. So basically, I finished my entire training, a fellowship-trained rheumatologist in 1992, and then I've been practicing in Pensacola ever since. Initially in an autonomous multi-specialty practice. It was sort of like a musculoskeletal practice, and now on my own for probably 13 years, maybe 14 years on my own. And so that's kind of the background on how I got to this location. But my main reason, and that I feel I have some authority to speak on some of these issues we're going to talk about today, is because I come from a family of physicians. My father was an orthopedic surgeon. My older brother is an orthopedic surgeon. My younger brother is a urologist. He is married to a radiologist. I am a rheumatologist. I am married to an ophthalmologist. My father-in-law is a retired internal medicine nephrologist, and my sister-in-law, my husband's sister, is basically an internal medicine nephrologist, but she's actually practicing at the Hospitalists right now. And so I have my own experience now of over 35 years, but I also have the experience of having lived in, grown up with my father, and the way that generation of doctors was revered, essentially, for their knowledge, skill, and experience. And essentially what they were the primary dictators of patient care, is how I like to refer to that. And what that means is no one would have dared think to alter an order, to deny an order, to say we're not going to do the prescribed treatments. That would have never happened in my father's and my father-in-law's generation. And the other thing that led to what I consider their happiness and their fulfillment in the practice of medicine is that they were completely in control of their professional destiny. How their knowledge and skill was used was under their control. Today, it's really not like that. Most doctors are floundering around. They might work at one hospital system for a couple of years and go to a different hospital system. And so I asked myself, how in the world did we get, from that place to this place? And that's part of what I want to discuss. The other thing about that generation of physicians, just so that we remember, they were hardworking. They didn't even have some of the advantages we have today, but they were not burned out. I mean, everything coming up at the FMA, there are all these resolutions about physician burnout. And I'm sitting there thinking, well, if you were an autonomous physician, you wouldn't be so burned out. You would be loving what you're doing. So in the early part of my practice, I was an unmotivated doctor. I called myself dormant. I wasn't really doing anything to kind of fight back against these issues. But as you mentioned, it was maintenance of certification, which jarred me out of my dormancy and motivated me to act. And part of that was I couldn't believe that my lifetime medical doctorate was being converted into this, what I call a 2-year certificate, And so I started to get active, but it was through that I came to understand and pay attention to these other factors that were really beating physicians down. And I have come to realize that the way physicians are practicing today, most of them, not myself because of the things I've done, but most of the doctors today are practicing under what I call medical feudalism, where the physician is the present day vassal and the administrators and the bureaucrats are the present day lords. And I think to myself, how did we get to where we were once in control and now they're in complete control? And honestly, I think physicians were kind of a perfect prey, really, to be sort of, kind of controlled and then neutralized, because frankly, we have a Hippocratic oath, as mentioned, and we are going to do everything we can for the patient, and we're going to try to make sure the patient gets whatever they need, even if we're under a lot of pressure. So I think, frankly, that our Hippocratic oath was really used against us. And back then, and even now, doctors just felt it was better to comply, just comply because we can do it, and yet our patients are going to still get what they need. But frankly, what I think is happening now is the patient is becoming more the victim of these predatory systems out there that are really, basically, the patient used to be protected, no longer. I hear it every day. I mean, the financial concerns in medicine, the fact that they're not getting their medications, they can't afford their premiums. So we really need to get more involved for that reason. But what happened along the way, of course, is that physicians felt like the system is so complicated, I can't make it on my own. So out of fear and uncertainty, they bargained away their private practice, their autonomous private practice, because they were told by the administrators, by the bureaucrats, that they would protect them. The bureaucrats and the minister come to us, you're going to get a guaranteed salary, we're going to give you some office space, you're going to see the patients, and then we're going to get all your collections, and we'll give you a little bit, but you will at least make it. And then on your own, you might not be so lucky. So I have been talking about this system of medical feudalism for a while now. And even in the past, I said, feudalism generally has been proven to be a failed construct for just about any functioning system. And I knew medical feudalism would at some point, or felt that it would at some point, come crumbling down. But I actually believe the pandemic has revealed to us that the overlords, so to speak, these administrators and bureaucrats, they didn't provide the protection that they promised to physicians. And I'm going to lay out a few examples of that. The most obvious, of course, is the failure to secure personal protective equipment before it was required. Like, you're supposed to be in charge as an administrator or bureaucrat. You're supposed to be looking for those things. You're supposed to prepare. And then when physicians were upset about it, or basically spoke out about the fact that they felt unsafe, then they were chastised, reprimanded, and threatened with the loss of their job. The other thing was that, you remember, when doctors went into these arrangements, what they were told was, we're going to protect you because you can't make it on your own, but look, we're going to give you a guaranteed salary. So guess what happens during the pandemic? They start telling doctors, you know what, that guaranteed salary, not so much. What we're going to do is cut you by up to 50% of the salary. Now, I know doctors who have been in these arrangements before. I've never been in an employment contract of this nature, but I know doctors who have. And they say that what they're told by the administrators and the bureaucrats is, you can't change a word in this contract because this is how it works for all the doctors we employ. There's no bargaining, but yet they can change it. How does that work? So the protection of the most basic tenets of their contract, the guaranteed salary, was not there. And again, I want to get back to this issue when the doctors would speak out again about being unsafe. They weren't speaking a falsehood. They were speaking the truth, but they were reprimanded, sanctioned. They were threatened with being fired. And, I think that's wrong, because even the most basic free speech rights of these doctors to speak the truth about what was going on was being challenged, and these doctors were potentially going to be fired. So I don't think they were protected even in their most basic rights. The other thing that was floated, and this didn't get much attention, but it was out there, and was this concept of the potential physician draft. I don't know if y'all have heard that, where the bureaucrats and the administrators would take the doctor, like a rheumatologist or whomever, and say, well, we need you here, And so I thought to myself, well, that's completely outrageous and outlandish, could never happen. And it didn't happen in this pandemic. But you know how that goes with the way these things always go. The original idea is outlandish. Everybody says that can never happen. Fast forward 5 to 10 years, they'll say, well, it's already been spoken about. We already talked about this, and it becomes not as outlandish. And I think to myself, well, wait a minute, they could come, and physicians, you could be a conscript of the federal government. That's basically what that's saying. You could be a conscript of the federal government with no control of your practice, no control of your labor, no control of then, of course, the fruits of your labor. So I felt that, that those are examples of course, the administrators and the bureaucrats going after doctors and not fulfilling their promises. However, for me, really, the big issue in COVID was what happened in large part within our own physician community, like the house of medicine, right? So I started watching things that were very shocking to me as a doctor of over 30 years. And again, growing up in the household of a physician, the quelling of vigorous medical debate, the intentional silencing of physicians, the assault on off-label prescribing, and the callous disregard for the sanctity of the decisions made by the doctor and the patient together in the exam room. And I just threw my hands up and was asking, what in the heck is going on here? That long-held tradition of camaraderie amongst physicians, where we respected each other's training and we allowed for differences in our medical opinions, that was callously discarded by what I'm going to call our own version of overlords. And I speak now within the medical community. And it was this version of our overlords that then allowed for the news media to get it wrong, for instance, and never correct them, and for bureaucrats and governors and things of this nature to do what they did. They would have never been able to do all of that had they not had this sort of blessing, so to speak, by that, what I'm calling credentialed elite class of physicians, So I am shocked at the fact that this went on in medicine. And these doctors, the other thing they did was they came in, think about this, this is a very unique thing, and a lot of people have not really commented on this. They went directly, so you'd have your Fauci's and your, Burks, and then all those folks, and even on a state level, you'd have these public health officials. They went directly to our patients and said, you do this, you do this, you do this. I never one time, not a single time did I hear, by the way, this is what we recommend you do, but you should speak to your personal physician. You should speak to your doctor to see whether or not these recommendations are good for you with your medical. You can't even pick up a book about dieting, okay, without that disclaimer being at the front. You should talk to your doctor. So they bypass the physician. And most of these doctors, I'm talking about this elite credentialed class of doctors, they haven't even seen a patient probably for years, but yet they belittled the clinical observations and the recommendations made by doctors in the clinic treating COVID patients. And that would go to, of course, the early treatment recommendations. And it was just insane how the doctor treating the patient got thrown out of the equation. The doctor treating the patient was not really recognized as the entity that the patient should look towards. So the physicians in this country, as it turns out, and worldwide, were told that you can't even question the recommendation of this credentialed physician class. they're sort of unassailable. You can't even question it, because that would be denying the science, that would be challenging the science. Well, I kept thinking, you know what, the science can take it. And the science has always been able to take it, but it was really these purveyors of the one size fits all policy that couldn't take it. And they used ridicule, censorship, threats of loss of licensure, and or board certification. That's something else we should come to exert their stranglehold. And I lament the fact that in doing so, they threw away a century of genuine mutual respect that we physicians afforded to each other as members of our great and noble profession, the profession of medicine. I mean, it's a very sad thing to see as a person who's been within this profession for as long as I have. So frankly, that's what I wanted to mention about how I felt the pandemic really kind of solidified what I had been saying. And it reaffirmed to me that physicians must once again become the sole determiners of their professional fate, fully in charge of how their knowledge, skill, and experience will be used. And we must reclaim our autonomy from hospital employment, insurance company networks, mega corporate pharmacies, Medicare, and now I will also add in there pharma, the elite credentialed physician class. Those are also in there because they are also inhibiting dialogue, education and dialogue between physicians, which is something that should never occur. So I want a resurgence of the autonomous private practice of medicine, and I think it's going to be a good thing for our profession. So I thought I would tell you what I did. This is a kind of a brief overview because we talked about direct pay models, which is where there's like a monthly fee. I don't do it that way. There's also Surgery Center of Oklahoma and all the things they're doing. But I felt I had a bit of a different thing that I needed to incentivize, because I want to incentivize chronically ill patients to get routine care in the clinic. So what I did was I set up, I call it fair cash pricing. And what I do is I base it on 12-month intervals. Now, this is for follow-up. A new patient will be different, but I base it on 12-month intervals. And basically, a lot of rheumatology patients need to be seen 3 or 4 times a year. So you will then get the office visit for $5 cheaper each time you come in. So let's say it's they need to be seen 4 times in 1 year, $95, $90, $85, $80. Okay, so basically, I think the patient appreciates that. It incentivizes. There's no real reason to miss your appointment. I mean, because the prices are very fair. For a new patient, for me, it's $235 for a new patient. And then I usually charge each year. Each patient pays one time a year, $35, what I call sort of service fee. I mean, just look, you'd be surprised how many service fees you pay and don't even realize it. But it's a way that I can help do some of the things that we need to do behind the scenes. And so what I did was, but how did I get to be able to do that? That's an important thing to know. Well, I started this private practice on my own in 2009. So here's the key for anybody thinking about doing this. What you have to do is, as soon as you say, I'm thinking about opting out of Medicare, you need to stop accepting new Medicare patients in your clinic that day. Go to tell your office manager, I don't want to take any more new Medicare patients. Keep the ones you have, until you're ready to make the transition. And then if someone becomes Medicare, you would keep them in. So I went from 2010 to 2016, which is with accepting no Medicare patients. So that's a 6-year period that I was able to change the milieu of my practice and bring in less Medicare. So in January 1st, 2016, I started my opt-out, and I was better positioned at that point, to start it. And I would recommend anybody wanting to do an opt-out of Medicare. And frankly, I think Medicare is the one you should go for first. A lot of doctors who want to get out of the system will go first to insurance companies and last to Medicare. But I think it's the exact opposite. I did it the exact opposite, and I think it's the exact opposite because Medicare basically, what Medicare does It's the one that sets all of these perverse incentives and torturous regulations up for you. Insurance companies follow. And I'm going to come to a little thing about all the things that poof like magic. That's why I call it opt-out magic. Poof like magic, it all goes away when you opt out of Medicare. The main reason, and this is another thing Charles mentioned in his intro, that I wanted to get out of Medicare. Now, I've been wanting to since 2010. You know, Medicare bullies doctors. Medicare is the ultimate bully. Let's just take, for an example, what they're doing right now with the fee schedule cuts, right? So back in, I guess it was early 2016, they implement MACRA and MIPS. Now, why do you think doctors complied with MACRA and MIPS? Do you really think that doctors thought that MACRA and MIPS was really like a true doc fix? Remember that? Oh, it's a doc fix. Well, no, it wasn't a true doc fix. Every doctor knew that. The reason they complied is because they didn't want the reduction in the fee schedule. Well, guess what's happening now? So all they all complied, and they're reducing the fee schedule. And in fact, it's more than they threatened to before. So Medicare, so you comply, good, if you've ever been up against a bully, we all know what they're like. You can do what they ask you to do, but they're coming back because that's what a bully does. And that's how Medicare is. They just bully physicians over and over again. So, but for me, the main driver for me to make the final decision was I had to do with the government mandated electronic health record, which basically has destroyed the doctor's note. It took this once relevant, succinct and honest document and turned it into the exact opposite: dishonest, voluminous billing and coding record. It's not even a medical note anymore, and it's filled with irrelevant junk data that the physician is forced to enter. Like, you can't even get someone else to enter it. You have to enter it. It's an absurdity on every level. And I wasn't going to do that. But the reason I finally let the shoe drop, because it's not an easy decision to make, but the reason I did was because Medicare was going to start penalizing me. And it really didn't have to do with the money, because, Medicare was going to start paying me a little less for saying, than the doctor who would have complied, right? But my thought was, okay, a doctor might understand if they read that Dr. McKnight's a penalized doctor. They might understand, oh, she's just taking less money because she didn't want to comply with something, right? What's the patient going to think? Have you ever thought about that with all these Medicare penalties that they're doing? The patient would automatically go to, well, she must have done something dishonest to Medicare. Maybe they reprimanded her for something. And I said, absolutely not am I going to be penalized by Medicare. So that was it. I decided I didn't want that, and then I got out, and so then I started, this fair cash, price system. And yeah, some people left, but a lot of people stayed. And the other interesting thing is that I have now where I'm getting more new Medicare patients to come in. That was a little bit of a hurdle. Medicare patients, you didn't want to come in as a new, because they wanted to go get established with somebody who would take Medicare. And I kind of get that. But now Medicare patients are having a hard time being seen anywhere. So they will come in. And frankly, I do have prices that are not just for the wealthy, not even close. A lot of people can afford to do and I feel like I have a service that they're willing to pay for. So there's so many wonderful things about opting out of Medicare that I can't even begin to tell you. I want to give you this is a quick list. It's not even inclusive of everything. What goes away, this poof magic thing, when a physician opts out of Medicare? You ready? MACRA MIPS, EHR mandates, Stark, anti-kickback, some aspects of HIPAA, maybe not all, False Claims Act, those RAC teams that can show up in your office and audit you at any time, 68,000, probably higher than when I looked this up before, ICD, now 10 codes. And the prohibition, I used to always think this was so hideous what Medicare tried to make doctors do. The prohibition of writing off copays or deductibles for poor patients, or charging the uninsured what Medicare pays, not what you bill Medicare. Most patients don't even realize that's even on the books. But let's give an example. If I charge, say I billed Medicare, I would have billed bills. I don't do that anymore. With sent Medicare a office charge of $160, but Medicare only paid me $80. Well, you would think then that when an uninsured patient came in, that of course the doctor would say, well, I guess I'd get $80 from Medicare. Let me charge you $80. Well, Medicare makes that basically, a form of Medicare fraud if you were to do that. They want you to go to the uninsured patient, basically bill them $160 and expect to collect $160. And I always thought that was unethical, and I didn't want to participate in that. And I think sometimes when these hospital bills that are sent out that are, $500,000, well, I'm not in any way, shall we say, covering the hospital, but what I will say is that's partly a Medicare generated rule. You pretty much have to bill the patient what would have been sent to Medicare, not what Medicare would have paid. So the greatest thing for me, so the day that I opt out of Medicare, I'm looking at my phone, and I start seeing emails from CMS. You realize doctors get emails directly from CMS, and they are always of the bullying nature. They're going to tell you, if you don't do this by this date, this is going to happen. And I just went, oh, unsubscribe. It was really one of the greatest moments of my life when I was able to unsubscribe to the endless bullying, threatening emails of CMS. So I'm about to finish. I just wanted to mention a couple more things. I went recently, or spoke to some younger doctors, and I was talking to them about what I call the happiness quotient, which is for physicians. Realize, this is what I'm trying to emphasize to them. The happiness quotient for physicians is different than the happiness quotient for administrators and bureaucrats. It's just a different equation. But for us, the equation is time spent at the bedside, time spent in mentoring and teaching, time spent in relevant, self-directed learning, time with our family and our loved ones, doing the things we love to do, divided by servitude to the EHR, trademarked MOC, and administrative and clerical duties. So we want that numerator to be very high and denominator to be very small. But I warned them that they must do that for themselves. They have to make sure that they have a high happiness quotient, because the administrators and bureaucrats they want the complete opposite. And they're willing to put physicians where they literally are doing, I know many of my friends, they're at home on the weekends doing tasks on their EHR. It's just an absolute outrage. So I'm going to end with this one thought about what I'm going to call the new medical ethic for the 21st century. I believe that the do no harm must include our, as physicians, commitment to protect the financial health of our patients as vigorously as we've always protected the physical and emotional, mental health of our patients. And I think it's our job to try to protect the patient from the predatory system that is in place today. And then I'm going to go a little further with the do no harm to say that must also apply, this is for physicians, to the way in which we treat each other, as what we saw in the pandemic was horrific. And we must not allow physicians to have their reputations, livelihoods, and their license to practice medicine put at risk because others in our profession do not like what they are saying or thinking. It's an outrage, and that has to become a physician-focused, job, is for us to make sure that our medical ethic incorporates that. And then we must include and foster the defense. This may be the most important because it really incorporates everything. To include and foster the defending the profession of medicine. And we should stand united as physicians to anything that denigrates our profession. And if we stick with that one in particular, everything else will follow. The care of the patient will follow, and they will be much better off. And of course, by protecting and defending our profession, we will make sure that within our profession, we go back to treating each other with collegiality and also with respect. And so that's kind of my synopsis of how I got here and where we are today.
Thank you. That was very informative and important to share. I do, before Charlie, I'll call on you in a second. You mentioned MOC early on
Mhm.
about kind of one of your right early motivation that
Yes,
kind of woke you up. And by the
yes,
way, as a producer, I did a lot of work for HHS and CMS, and
uh-huh,
they were a pain in the butt client.
right, right,
So
I can imagine. Yeah,
as
yeah.
a, so yeah, MOC. Maybe you could just expand on that a little bit.
Right.
What
So,
happened?
so what happens is, I mean, I can give you a little bit of my personal experience because it did formulate the way I feel. So let's see what year that was. I finished internal medicine in 1989, and I then passed my and wait a minute, no, 1990, excuse me, in 1990. That's the first year. I was young and naive. I didn't know. I went and took my internal medicine board, and I'm happy I passed the thing. And then it turns out that my internal medicine board was only going to last 10 years. That's when they started doing what we call time limited certification. The year before me, 1989, those doctors were grandfathered. They never, ever had to do what I had to do. Well, you know what? I was playing along with that. I really was. I was like, okay, every 10 years, I'm going to go take a test. And so I'm preparing to do that. And there were some things I could elaborate on that happened in between that were a little bit disheartening because of this. But I'm preparing to take the test in 2014. And I realized that what they're going to do is your 10-year test will not be a 10-year test anymore. You still have to take the 10-year test. But if in 2 years you didn't do something called maintenance of certification every 2 years, then the 10-year test was only your board certification was only valid until that. You see where I'm going with this? So it was a money-making grab. It had never been proven to improve anything, quality of care, physician, I guess the intellect or what have you. Nothing. They didn't prove anything. They just decided they were going to impose this mandate on doctors. And so I went to my physician colleagues. I went first back to my medical society, my local medical society. No one heard of it. And guess what? They weren't that riled up about it, frankly. And so that's what we face in medicine. When we start bringing these to our colleagues, they're so buried. They're like, MOC, I'll worry. And guess what? It's now starting to get a little more traction. But I have been working at the FMA, Florida Medical Association. Every year I've sponsored a resolution, and we actually have very strong anti-maintenance of certification language. And actually, I think it's going to go somewhere. We're protecting the doctors in the state of Florida, and I hope it catches on. I really do.
Nice, nice. Charles.
Thanks. Let me share my screen real quick to ask a couple questions. So one vendor that we promote at Freedom Hub is Dr. Arshad's Wow Cash Appointments app.
Mm-hmm.
And if you go to our site, your-mp.com, and click Your Health, you'll see under here a section that's in the works about the Wow app. This actual paragraph is incorrect what it is, but if you click on it, it's still, that link is correct. And this is where doctors can list their prices and get paid by the worker using the app. And it really facilitates that cash transaction that is the source of independence for doctors. And even if you want to keep your Medicare a bit, you can offer a couple appointments a week or a month if you want to start that source of cash and help you transition. Because I think so many doctors are afraid to go cash, whether it's subscription or per visit. There's infinite ways to do it. I think the point is just to start. So this is one way where you can start working with us and the Wow app. And our brokerage, where we sell sharing with HSAs, which really help pay for all these cash events with doctors. I'm also the lobbyist for the National Health Federation, and you mentioned the bullying doctors face from licensing boards if they dare to follow the Hippocratic Oath. and prescribe early during COVID, especially. And in Oklahoma, there's a bill to replace licensing with competitive certification, and the certification never could be monopolized, which is something doctors fear when they hear the word certification because of MOC. Under the bill that comes out of a think tank, any kind of organization could register with the state to offer certification, and there's no limit on how many could do so. But when you follow those certifying criteria, you don't have to be licensed. So, it's a big change, but I think, as you mentioned, COVID has opened people's minds to big changes. And if we don't consider big changes, we'll never get the better world that all of us want. So I'll put those both in chat, how to replace licensing and how to facilitate cash payment. And let me go back to this. Maybe Jim, you could help me stop sharing if I haven't already. But do you want to respond to?
What I would comment about too is, many people, myself included, I don't use the electronic health record. I've developed a charting system within that, but I use a management system. I use McPractice. I really like it. But when a doctor is in particularly the transition phase, when they're thinking, should I go cash, or I want to at least offer some cash pay, and maybe I'm going to have some insurances or whatever. If you're using any sort of billing company of any kind, they want a percentage of your cash pay too. It's like the most ridiculous thing. So if they take 4% or 5% of your collections for quote, billing, which that's a whole joke too, because if something doesn't go through, they send it back to your office. You have to work it, and then they still get the 4 or 5%. But they want to do that with cash. So maybe, and I don't know, I haven't looked at the app, but maybe that would be something a doctor who's trying to be, shall we say, putting the foot in the water a little bit, and maybe they would have the app. It wouldn't even, because that would not necessarily go through the office. Is that what you're saying? Somehow the patient pays on the app. Is that how that goes?
Yeah, it's like Amazon. So the Wow Cash Appointments app will list your charge, but a little bit higher.
Yeah, because they take a little percentage.
Yeah. The patient sees the higher charge, but you get 100% from escrow paid immediately upon completion of the appointment once you upload the medical note, because the patient wants to keep the records themselves. And so that if they're found unconscious elsewhere, the app has their records, and they could show the doctor what they want to have public. But it's a straight cash transaction app. And the user can embed their HSA in there, or they could route a process through the sharing organization like Zyne or Zadara, or the TPA if it's a big employer plan. But it's a sea change. There are other companies too. Paula Muto, your fellow specialist, has UberDoc, where doctors can list their consult price, and that's a big app with a lot of specialists. And those doctors are all normal doctors taking insurance and Medicare, but they want to dip their toe in the water of cash, and so I'll list my consult price, $200. And there's other vendors discouraging bundle pricing from surgical centers, facility anesthesiology, surgery all-in-one price. A lot of those, Wow, Savos, Fair Cost out of Kansas, Misha, whatever Sidney Haydoff pronounces his venture. So there's a lot of people really trying to facilitate this cash revolution.
It sounds wonderful. Obviously there's even a form of transparency, obviously, within all of that too, which is very helpful. And the predatory system that's in place now, they don't want any transparency at all. So any of that, just displaying prices for people to see is, I think, going to be a very good thing.
Yeah, and that Medicare rule you mentioned, I've heard that before. That's just Orwellian. You can't give a poor sap a decent charge because it's not what Medicare wants you to bill them.
It's insane. It's absolutely insane. And now you could ask the question: is Medicare really going to come at you for that? Maybe not. But in today's day and age, where things are weaponized against people who think a different way, yeah, then maybe they would. Yeah, just saying. So people got around it by saying the way that I had heard. Oh, you can get around it if you say you have to pay it all up front. Like you can't pay $35 now and in 2 weeks pay me $35. You got to pay me all up front, whether that was legit or not. But it doesn't matter now. I've been out of Medicare as long as I have. I never followed. I basically gave my patients a cut rate, something like Medicare would pay. That's how I did it. And whether they didn't like it or not, but it's an unreasonable. And if you tell patients that, which I do every now and then, things like that, they're shocked. And that's part of the problem. That's why doctors need to take the time to educate patients, because they have no idea these things are out there and being done to them and their physicians.
And are they paying your bills with a credit card or a health savings account?
Both. I have all that. That comes through. So credit cards, we use a lot of credit cards. Every now and then somebody brings cash up there, but I don't have that worked out. Like, I don't know that number. Maybe I could get that back to you. Like how much it comes through, how many people are utilizing their health savings accounts, for the full cash pay. I'm not sure about that.
Well, the problem with the health savings account, of course, is that the dumb government prohibits you from funding them once you retire. You can spend them down. So a lot of us Asians are now promoting this money doubling account. It's called the health matching account out of Houston. And that's popular for Medicare retirees because you pay, for example, you want $5,000 in a prepaid visa for your costs. Especially it's good for chronic patients or an elective surgery. Maybe you want 10, 15, or 20 grand for, a lot of teeth work. Old people have a lot of teeth expenses. So you're going to pay a certain amount per month for 3 years. It's going to be matched with a formula based much like a sharing organization. It comes out of a Milliman actuary firm. But the point is, if you're going to use healthcare, if you're a high utilizer, this is a way to cut that out of pocket in half. If you can be patient, let the money grow over 3 years, and then you've got a prepaid visa for all the out of pocket. But that's another powerful tool to facilitate the more expensive cash treatments that are out there and are going to be increasing in frequency because already Obamacare deductibles are so high. So Obamacare has made people into cash patients because the average out of pocket is $6,000 with health insurance. Anyways, this is a good conversation to have.
Well, I mean, are you speaking of like right before someone's ready to retire? Is that what you're saying? Like you build this account over the 3 years right before retirement, or you can do that at any time?
At any time. So a young family may want to build some money to have a baby or braces for their kids or any kind of elective, or if you're chronic, half the country now is chronically ill, right? So that if you're a higher utilizer, especially the health matching account makes sense. I'll sell it with sharing because insurance has networks. Sharing doesn't. So sophisticated folks know that sharing is a better deal than insurance, medical cost sharing. And then the HSA, I'll include that. And I tell them, don't even use the HSA. Use that as a tax shelter to build $100,000 for retirement. And if you are sick, use the HMA because that's better for out of pocket. So I'll sell you 3 things.
I think that's interesting.
But we're all about the cash revolution, how to make it affordable. And the big thing is the concierge to help you find cheap drugs, tests, and specialists because patients are intimidated by this cash model.
They really are. And they feel trapped by it because they're like, well, I've got insurance. I want it to pay, but I'm like, it's not going to pay. You're gonna come out of pocket, but you're gonna probably come out of pocket higher than if you would have paid the cash pocket price. So it's crazy, yeah.
Christina, actually, before you answer or bring up your question, Charlie, it's older people, not old people. Sorry.
Sorry, we're a snowflake-free zone here.
Okay, well, as a Medicare person, anyway, with an HMA, thank you, which I like, especially for dental work. It's great. Okay, Christina, you're up.
Hello.
Hey.
So, you guys know who I am. I actually work in medical tourism, which is for the most part, cash pay, mostly self-funded, this kind of thing. As far as outbound, Americans and Canadians going somewhere else for something their insurance won't pay for, doesn't cover, or it's just too expensive here. And yes, the Obamacare has made it so sometimes it's just cheaper to get the surgery somewhere else than pay the deductible. But a couple things you mentioned that I think might affect, and I'd like your feedback on this, what we call inbound medical tourism. So in spite of America's high cost, of course, there's people in the world that say, oh, I want to go to the United States for my healthcare. Those are usually, high value people. But I'm just wondering, you mentioned that these rules with Medicare and things will they have to, of course, apply to Stark and kickback laws. So, there's no referral fees or anything like that. But also that thing you mentioned about being able to charge less to a cash paying patient than what Medicare would have you do. And of course, that's, the great draw in going abroad for us. But I'm wondering when people come here, and a lot of them, of course, are drawn to the large centers like, Cleveland Clinic and Mayo, et cetera. Unfortunately, so are you saying then that because undoubtedly these hospitals are part of Medicare or Medicaid, that are they impeded then from charging a cash price? Are they literally having to charge, or the prices that, like you're saying, Medicare would make them charge?
Well, I think that's quite possible. I mean, you've got the big hospital systems. Certainly, they're not going to want to get, in Medicare's grill, so to speak. They're not going to want to disrupt. But that is, again, I've been out of Medicare now for quite a long time, and who knows, maybe something has changed in that respect. Again, I unsubscribed from the CMS emails. But when I was still in Medicare, that was an absolute. You had to charge and expect to collect from the uninsured cash patient what you would have billed Medicare, not what Medicare paid you. And you realize, there's always a much higher bill sent than the payment. Totally. And so maybe they wised up. I mean, one option would be to, if you know Medicare is going to pay you, and you're only going to get whatever that fee is, maybe you would only charge those people. You know what I mean? You would charge Medicare less because they're only going to pay you anyway. What's the point of this huge write-off? I don't know how the big hospitals handle it, but I do think it's a problem for them. They have to present these large bills.
Yes, and I think that's just as I look to help people save money when they go abroad. Same thing coming in here. Said I know some are big, high value. They come from Dubai or whatever, but there's others that just want the quality of the U.S. healthcare. And I did not know that. I'm going to try to find out, because again, I was
going to just mention this really quickly. Dr. Lee Gross has a fantastic story that he tells of a woman with thyroid cancer who I think she may have been from the Bahamas. I mean, she was somewhere close, but she didn't have, so she's in South Florida. He got her there. He worked it out with one of the hospitals down there, and they were able to do it. So it can be done, but he's got a good story. You might want to look it up. He's told it several times in his talks. Yeah. Dr.
Lee who?
Gross, Gross. He's a direct primary care advocate, practitioner of direct primary care.
Okay, would I find him on LinkedIn or podcast?
Yeah, in fact, maybe, but I know I can. Connect with me, and I'll get you his contact information or send you some of his talks. Yeah, because I'm on LinkedIn. Yeah,
that would be awesome, because I totally feel what you feel. Unfortunately, the medical tourism, they've focused a lot on, JCI accreditations all over the world now. And, they're just feeding the beast. And I've always built my services. Hey, no, go with an autonomous doctor. Don't worry about the hospital. So I'm totally on board with that. But this was great information because, again, coming this way as well, that's a great thing for people that are bringing patients to here to make sure they're not being forced to charge these higher rates because of Medicare. So
absolutely. Cool. It's a good question to ask. You're welcome.
Thanks very much, Ellen.
Thank you.
Jimmy muted, but I guess I'm next. A couple questions. I know we're almost out of time here. You mentioned patients as victims of the healthcare system. By example, you mentioned the unaffordability of medicines and insurance. And then you mentioned some of the suffering doctors have faced by leaving independence to become employees in big hospital systems. And you mentioned COVID as a trigger, but you didn't mention a couple things that are pretty important, at least as trends in our show. And that is for patients, what about the fact that, proper medical care sometimes kills them? And as according to Robert F. Kennedy, the third leading cause of death, iatrogenesis, death from medical care. And we know from John Ioannidis and different studies that a lot of the so-called peer-reviewed studies aren't reproduced. And this whole pharma model has problems. And we know the real epidemic in this country is chronic disease. And what about the feeling some experts have that allopathic medicine has failed because of that chronic disease epidemic? And one nice thing about cash, whether per visit or monthly, that time you get with a patient, we found, has changed doctors. It's made them more open-minded. It's made them more integrated. It's a tough topic for some doctors. They get a little defensive, but a lot of doctors welcome it because patients want more of an all of the above strategy. Mm-hmm. That's the one thing is, have you found that in your own practice, opening of your mind, your practice, to deal with more, the demand for more integrated care? And then the other part of my question is, you mentioned all the sufferings doctors have had as hospital employees, but you didn't mention the vaccine mandate, which chased so many independent thinking doctors out of the system. And a lot of them have had to start independent practices to survive.
Well, that's good.
Some of them
that may wind up being good. Yeah, that may wind up being good when you think about it.
Like Dr. Bowden, she's suing, is it Houston Methodist Hospital, a Breathe MD. She's got more business than she ever could dream about because of her notoriety. So those are the two things. Mm-hmm. I can repeat the question if you want.
Well, I agree with you that I was completely against vaccine mandates. In fact, we have a resolution going to FMA this year that is going to ask them to overturn. We didn't want them to do this 2 years ago, where they recommended vaccination for any healthcare worker, no matter their age, no matter their risk from COVID, no matter their risk from the vaccine. So yes, I'm completely on board with going back to more of the traditional way we did it, is where we looked at risk-benefit ratio. It's kind of a simple concept, but that again, it's hard to get the whole picture out. But that's part of what I'm talking about when I talk about the overlords in the profession of medicine that are our own. They're the ones who did that. They're the ones who allowed all those things to go forward. They silenced doctors. So that's part of what I want to work on. It happened, and now we have to recognize how it happened, and we have to definitely go on to do it. And we're going to FMA. I've got a couple of really controversial resolutions that I support that are controversial to others, not to me. They make a lot of sense. So, but I agree with you. I agree with everything you just said in the sense that I hope those independent doctors who did not want to take the vaccine basically are now going to be kind of in our camp. Our camp has been kind of small. Come do independent, autonomous, private practice. And even doctors who are not as well known as Dr. Bowden. I mean, again, I'm making it on, with my mostly cash practice. I mean, I still do a little insurance, and it's such a wonderful, the happiness is so great, like you say. Oh, and let me get to the point about allopathic. I don't consider allopathic medicine to be a complete failure, because I've been in rheumatology, and there have been huge advances in medicines that I've seen do dramatic things for rheumatoid. What I have appreciated is this more of an integrative part. We've never been able to completely fix the fatigue and some of the pain. So, and then of course the antiviral properties of certain vitamins. I mean, I'm doing all that now. Whereas maybe a few years ago, I wasn't really doing that. So I have vitamin IVs for fatigue and pain. I have little recommendations every cough, cold, and flu season. It's obviously C, D, and zinc. So I'm doing those things, and it is more of my practice now than it was before. So I get the point that you're making, but I would not be so emphatic as to say that allopathic medicine has been a failure. And the other thing I mentioned earlier was this pharma and the credentialed elite physician class, that's something that needs some light shed on it, because all of the things that you're mentioning are correct about that. And their recommendations, I think, are now looked upon with some skepticism. You know, that's just the way that it is. Yeah.
We are coming up at the top of the hour. Ada, stay with us because you can ask your question in a minute. But for our audience, how can people reach you or follow you?
Okay, so I am on Twitter at Ellen McKnight MD, and you can get onto Twitter. I'm on LinkedIn. I think it's just under Ellen McKnight. And yeah, I'd be happy for people to follow me. They can direct message me. I'm happy to talk to anybody. I've had many physicians call me in the past about this, and we spend time on the phone discussing these issues. So if there is a doctor out there who wants a little more one-on-one conversation, I'm happy to do that too.
And if anyone's in Pensacola, that area,
Yeah.
they can look you up, right?
Absolutely, absolutely.
Website?
Oh, you know, I don't really have a functional website.
Okay.
Just call my office, Ellen McKnight. They can look me up on any of the things, but my website needs a little work. But they certainly can call here. I'm actually been practicing here for, I don't know, a long time, so they can find me. It's very easy.